In the last lecture, we talked about hypertension, or rather uncontrolled hypertension. We talked about, for example, essential hypertension, where there's an increase in your systemic vascular resistance, which will ultimately increase your wall tension. And we talked about how the increased wall tension leads to an increase in myocardial oxygen demand. And we talked about how does the body compensate for that increased O2 demand through a process of left ventricular hypertrophy or concentric left ventricular hypertrophy due to the pressure overload, which ultimately will decrease the wall tension and help to decrease the O2 demand to prevent myocardial ischemia. And we looked at this picture here to represent left ventricular hypertrophy. And we said that as you increase that H value, and you plug in that H value, the increased H value into Laplace's law, we can see that by increasing the denominator, it will ultimately decrease the value of the wall tension and therefore decrease your O2 demand. But what happens if this left ventricular hypertrophy progressively gets worse, or rather the left ventricular hypertrophy increases where the wall thickness increases so much that this left ventricular wall becomes so bulky and leads to a non-compliant left ventricle? First of all, the compliance, by definition, is a change in pressure over a change in volume. So if we were to look at the cardiac cycle, we can say that the beginning portion of this cardiac cycle is a movement of blood from the left atrium into the left ventricle. So as the blood enters the left ventricle from the left atrium, or the blood moves from the left atrium into the left ventricle, if you have a compliant left ventricle, it's going to allow a greater amount of volume into the left ventricle during diastole, or the relaxation period of the left ventricle, to generate a preload that's adequate to stretch the myofibrils and therefore generate an adequate contractile force to lead to a proper cardiac output to perfuse all the vital organs of the body. But if this left ventricle becomes so bulky and prevents an adequate amount of volume to enter into the left ventricle during diastole, that's going to decrease your preload. And in using the Frank-Starling curve, we know that as you decrease your left ventricular end diastolic volume of your preload, it's going to affect your cardiac output. So if we were to look at this pressure volume curve, the blue curve represents a normal, healthy left ventricle, and the reddish curve depicts a ventricle that's beginning to have diastolic dysfunction. And we can see that as the volume, or as the blood enters into the left ventricle, we can see that the pressure increases more rapidly in a heart that has diastolic dysfunction, although the volume is less compared to the normal healthy left ventricle. So therefore your preload is going to be decreased, or the volume of blood in your left ventricle is going to be decreased, although the pressure, the left ventricular end diastolic pressure, is going to be increased in the left ventricle in a diastolic dysfunctional left ventricle compared to a normal healthy left ventricle. So therefore, you're going to have a decreased cardiac output and an increase in left ventricular end diastolic pressure for a heart that's going through diastolic dysfunction. And we'll see what else happens is the fact that as you increase that left ventricular end diastolic pressure in the left ventricle, this starts to compress the subendocardial vessels. And as we know, the left side of the heart perfuses itself through the coronary circulation during diastole. So by increasing that left ventricular end diastolic pressure and compressing on these subendocardial vessels here, that's going to decrease your coronary blood flow and therefore decrease your O2 supply. And once again, as you increase that left ventricular end diastolic pressure in a diastolic dysfunctional heart due to its non-compliance, once again, you're going to increase that wall tension. And this combination here of increased O2 demand and a decrease in O2 supply will eventually lead to myocardial ischemia, where there's an imbalance of the oxygen supply and oxygen demand. So we talked about earlier, when there was a imbalance between the O2 supply and O2 demand, the heart was able to compensate initially through a process of concentric left ventricular hypertrophy, and ultimately that was able to decrease your O2 demand using Laplace's law. But that becomes counterproductive once this left ventricular end diastolic pressure builds up, as we talked about here, and decreases your left ventricular end diastolic volume, which is your preload, and therefore begins to decrease your contractility or your cardiac output. And then we said that as that pressure builds up within the left ventricle, it starts to compress the subendocardial vessels during diastole when the blood is going through the coronary circulation to perfuse the heart. And that combination, we said, leads to myocardial ischemia. And myocardial ischemia, or ischemic heart disease, will start to present as angina. The patient will start to have chest pain. And later on we'll differentiate between a chronic stable angina and an unstable angina. And we'll talk about these in greater detail in the following lectures. But right now, as an overview, the ischemic heart disease can be corrected through various factors such as pharmacological agents, which we'll talk about later in the pharmacology lectures. But ultimately, we're trying to prevent a process of myocardial infarction where a patient will come in with chest pain. And we'll talk about the treatment management of myocardial infarction. For example, the acronym MONA, in which you treat the patient with morphine, oxygen, nitroglycerin, and aspirin. Morphine is to try to treat the pain so that the patient will no longer perceive this impending doom event and therefore hope to decrease that sympathetic tone that's generating all those catecholamine and stress hormones that will ultimately increase your O2 demand, because that's going to increase your chromotropic, your dromotropic, your inotropic effects on the cardiac physiology, and all of those factors will increase your O2 demand. You obviously want to supply oxygen, and we'll talk about nitroglycerin. For example, nitroglycerin is a nitrate. Here you go, nitroglycerin, which helps to vasodilate, and in fact it helps venodilatation more so than the arterial dilatation, and that helps with the coronary blood flow to reestablish proper blood flow to the coronary arteries to try to treat that myocardial ischemia. And we'll talk about aspirin, an antiplatelet, to try to prevent any clot formation within the coronary vessels. We'll talk about the treatment management. We'll also talk about the cardiac enzymes. We'll talk about the EKG phenomena that take place. For example, the dysrhythmias that may take place with myocardial ischemia, myocardial infarction. And we'll talk about, for example, bradyarrhythmias. Patient becomes bradycardia. And we'll talk about all the factors, for example, the pathophysiology of coronary artery disease in the following lectures.